It's what that time costs you as a person. Like, you're sitting at a kitchen table at 9 p.m. documenting a visit that you made at 10 a.m. Your kids are in the other room, your dinner's cold, and you're trying to remember the exact details of a wound you assessed 11 hours ago. That's not a documentation problem, that's a quality of life problem, and it's why nurses leave.
Yes, that's definitely one of the reasons why nurses leave, is because they're not, because of the time that's involved in it. The other challenge, I think, is when I get new nurses in, they think it's going to be easy. I'm going to go to home care because it'll be so much easier. All you do is you see 4 or 5 patients, you sit around, you have tea, you chat for a little bit, you have a good time. They really do not understand what is involved. And so they are really ill prepared for the experience.
Welcome back to Inside Home Health. I'm Arvind, Sarin, CEO of Copper Digital, and I'm here once again with Kathy Duckett, who, after 4 sessions, I'm starting to think might be the most patient person in healthcare, unfully intended. Last time, we talked about the referral roller coaster, the fax machines, the 76% rejection rate, and the face-to-face nightmare. And I ended the episode by saying that next time we'd walk through a day in life of a home health clinician. And people, today is that day. Here's why this episode matters. I talk to investors and tech founders all the time who look at home health and they see numbers on a spreadsheet. They see PDGM categories and LUPA thresholds and star ratings, but I feel like they have no idea what happens between 5:30 in the morning to 9 o'clock at night for the nurse who's actually delivering the care. And I didn't either until I started spending time with clinicians and just listening. So today, Kathy is going to take us on a ride along. We're going from the alarm clock to the last Oasis field at night. Kathy, are you ready?
I'm ready.
Awesome.
I'm ready.
Okay, let's get started at the very beginning. The alarm goes off. A home health nurse is about to start her day. What happens before she even sees her first patient?
So, it's interesting that you asked that question, because when we get new nurses into home care, we have them do a ride along. But the ride along starts by meeting them at their first patient's home. So this whole idea of what happens before you even start your day, which is a vital part of what home health nurses do every day, the new nurse doesn't see because she just sees it from the beginning of the patient experience. So let's start with the nurse. The alarm goes off. Invariably, we hit snooze again. We're not quite ready to get up and face the day. And again, it's a little bit different for everybody, right? Because if you're a mom with young kids, it's going to be a different morning than if you don't have any children. Then you have more time to yourself, or you may have a ton of pets that you have to take care of first. The thing I really want to emphasize is that in addition to the stuff I'm going to talk about, she has all the other things that she has to do they have to do as part of their morning. And so we can't forget that in the middle of trying to do this stuff I'm talking about, they're also trying to get breakfast for other people, feed the pets, do all these other things as well. But let's just focus on what we have to do for work. So the first thing you have to do is you plug in now I'm assuming you have a laptop. So I'm assuming that it's not a paper job. And there are still home health agencies that are paper. So it's a little bit different if it's paper.
So
but
like take a notepad, carry your
right.
notepad.
They're calling into the office. They're doing that. They're doing it that way. But let's assume that you have an electronic medical record and that you're doing it this way. First thing you do is you plug your laptop in. You've probably left your laptop plugged in all night. And if you've done that, that's great. Now you're turning it on. Then the first thing you have to do is sync it. You have to sync with the EMR system, because what's probably been happening after you were done is that stuff has been coming through. So some agencies have intake that closes at 7 o'clock. So you could look at 4:30 in the afternoon thinking that your day is set for the next day. And when you pull everything up and sync in the morning, all of a sudden your schedule's been changed.
Got it.
Right. So you have to say, all right, who am I seeing today? That's the first thing you do. And it doesn't happen instantaneously. I mean, you're syncing based on your internet provider. Oh, you have to give it time to do that. let's say it all goes smoothly. Let's say there's no electronic glitches, because if there are electronic glitches, now you're calling into the agency going, hey, I can't sync, and all those electronic issues that can happen. Let's say that happens smoothly. Many years ago, when I first started in home care, when we didn't have electronic EMRs, we could pretty much set our schedule. And if we didn't get a beep or a notification on our phone that something had changed, then our schedule was our schedule. So what we used to do was we used to call patients the night before and say, hi, Mrs. Smith, I'm planning on being there between 10 and 12, because I was able to do all of that, looking at what my route would be and all that the night before. Nowadays, you cannot guarantee that you will have not picked up a new start of care. The start of care that you had fell apart, so they put another one in. The patient you were planning to see went to the hospital, so the visit's been canceled. They forgot they had a doctor's office, so they called last night at 5:30 and said, hey, I'm not going to be there, and the schedule is being changed in the office while you're getting your syncing. But once that happens, once you know who you're going to be seeing, then you have to go and look at where they live, because your route is determined geographically unless there is a reason for a timed visit. Often there's not a timed need. There might be needs to be changed in the morning, but that's pretty flexible. You're starting your morning at 8 a.m., right? So you could do it at 9, you could do it at 10, you could do it at 11. The only things where timing is really important is new patients with diabetes, because you want to get in there. If you're teaching them insulin, you need to get in there in the morning, early morning visit before they take their insulin. And many IV antibiotics are timed. So if you may have a patient that you think you could easily see with geography in the middle of the day, but because of the timing of the IV, it needs to be towards the end of the afternoon, by 4 o'clock or whatever. So you have to look at what's happening with those patients as a indicator of what your route's going to be. And then you have to look at geographically where do they live in order to get an idea of when you're going to see those patients.
Got it. So you have to sync the schedule, check the schedule, and plan your route. Got it.
Right. And then what you do after that is that now you go back and you look at what you're really doing with each one of those patients. So I need to make sure that I have
reviewing the charts.
Yes. So with ongoing patients, yes, I'm reviewing the chart. And new patients, I'm looking at what the new start of care is. What does the referral say? And because what I'm looking at is, what do I need to do? What supplies do I need to have on hand? Every home health agency has a trunk supply kit. So there are certain supplies that are clean supplies that we carry with us in a special place in our trunk. And they're in bins and they are designated clean areas. So we generally give the clinician a bin where she keeps the supplies in the bin, because they can't just be thrown in the trunk. They have to be clean, right? And covered. So they have a trunk bin.
So these supplies stay with the clinician. So she may be starting at her home. So she's got a bag full of DME in her trunk.
Well, not DME, DME, more like wound care supplies. So she'll have some wound care supplies. Now, technically, the patient should have all the supplies they need in the home. It should have, for a new patient, if it's a wound care patient, it should have been delivered. If it's
like the doctor would have sent some supplies and the rest would have already been ordered and must be on the way?
No, either the discharge planner from the hospital may have sent home some supplies, although they used to send a lot, but now they can't. So they send maybe enough to get you through the next day or 2 days. They have also probably hopefully they have called for more supplies for delivery, but at least you're hoping on a start of care patient that the wound care has been ordered. You know exactly what you're supposed to do. So hopefully the patient has come home with some supplies, but you also have to have supplies in your car just in case you walk in the home and there's no supplies, because you still have to do the wound care.
Then what is the office? So the car is basically the office. I mean,
because
in a hospital, you've got a nursing station and supply rooms and colleagues right there. In home health, it's you, your bag, and your Honda Civic. And that's the whole operation.
And you don't want to go into the office if you don't need to. Again, millions of years ago, we used to start our day in the office and end our day in the office, right? So if we didn't have something with us, we would walk into the office, get our schedule, talk to the schedulers, get our supplies, and then head out for our day. But for many years, we've changed that dynamic. So we start from home. And for some people, their home can be 30 to 40 minutes away from the office, right? So and the office would rather have them spend 15 minutes driving to the first patient, right? And not going into the office.
So then the schedule is a suggestion, I guess. I mean,
The
it sounds like it's more of a suggestion than like a very specific plan. And you map out your 5 or 6 patients, and then the first call of the morning, usually I've heard, blows it all up.
Right. So what happens is that it's not the schedule is really who are you going to see, not when are you going to see them. And right. So that's the plan. And then
so that is fixed.
Right. And so then I determine when I'm going to see them. And then you're right. Then I determine what supplies. What do I need? What do I need to make sure that I have? Because if I need to go to the office first, because I don't have it in my trunk supply, then I need to build that in, right? And I need to build that in before I get on the phone and say, hey, Mrs. Smith, I'm planning on being there at. So then I determine approximately what time I'm going to see patients. And I usually put a 2-hour window because I have found, and I'm not the only one, nurses have found that if you tell the patient you're going to be there between 9 and 10 and you show up at 10:05, you're late and they're upset. If you show up at 8:45, they may be late because you're early. So you want to give a big enough window that you can be running a little bit late from the previous patient and still be within that patient window. So I may think that I'm going to get to your house at 9 o'clock in the morning. I'm going to tell you I'm going to get there between 8 and 10. Because then if things are going a little bit faster, I can get there early and I'm within that window that's acceptable to you. If things are going badly, then I can be a little bit later from my brain, but within that window so you're happy.
And this is such an important point, meaning it's important for the outsiders. And I'll tell you why. Initially, I created a voice agent for patient visit confirmation. And of course, I had no idea that you don't have a specific time that the clinicians are supposed to go. So the voice agent would say, okay, the nurse is going to arrive at such and such time. Is that okay? And they'll be like, yes. And then when I show that demo to one of these companies in Florida, they're like, oh, no, we don't have specific time. So that's why it's just so important to understand how things actually work. On those lines, I have a question, like what's inside the bag? It's always been like, I've been very curious about this. Like, what's actually in there? Is it like, Mary Poppins situation where you pull out a blood pressure cuff and, those wound supplies and a stethoscope and hand sanitizer and I guess somehow a laptop and an iPad as well with your lunch that you're probably never going to eat. So what's inside the bag?
So what's in the bag? That's a great question. The bag is actually divided into different areas. You have a clean area and a dirty area in your bag. So there's many things in the bag, but there's some things that are going to be in the dirty that may end up in the dirty side of the bag. There'll be things in the clean side of the bag. And there's things that you might not think about, like paper towels. So you have a stethoscope, you have a blood pressure cuff, you have a thermometer, right? You have alcohol swabs because you have to clean your equipment. You're going to have scissors. You're going to have a place for your laptop. You're going to have some supplies that will be easy to get to that you might need to get to. So you might have some 4x4s. You will have some surgical tape. You'll have you have your alcohol swabs. You may also we have the disinfectant wipes that we carry because of COVID and needing to, alcohol. Everything used to be alcohol swab, and now it can't be because it has to be a higher viral agent to kill that as we go to different patients' house. We'll have disposable gloves. We might have a pair of sterile gloves in there as well. We're going to have tape, so measuring tape, so we can measure wounds. We'll have some sort of, what else will we have? Oh God. Potentially you could have things like Q-tips, sterile Q-tips for Q-tip swabs and stuff that you might need that you can get to. And then you'll have a dirty part of your bag.
A lot of stuff for wound care, usually.
Right. Measuring stuff. And in addition to that, then you'll have things like, you'll have your PPE, you might have your PPE equipment with you, your sterile stuff for your personal protective equipment with you. You'll have extra masks. You'll have, those kind of things that you have to carry with you as well. In addition, you're going to have your trunk and you have your trunk. Don't forget, you have your trunk supplies. So then before I go into your house, I'm going to open up my trunk supplies, pull out what I need. I'm going to stick those in my bag. And the whole bag needs to weigh less than 20 pounds because we have to be very aware of the weight restrictions for nurses. What's comfortable to carry, because they're carrying it all day long. They're getting in their car, but they could be carrying it up 4 flights of stairs. So we need to be aware of how much everything weighs and how easy it is to clean the bag. There's certain things that people don't think about. The bag has to be cleaned every day, right? We're going between patients' homes.
Plus, the partition you mentioned is very important. I think having that clean and the soiled partition is very important.
We'll carry blue pads. The blue pads, like people have seen that in the hospitals, because we have to put our bag on things and you can't put your bag. There's only certain surfaces that your bag can go on, and you want to make sure your bag is protected and your equipment is protected. So you have to have a clean place. And walking into patients' homes, you need to, sometimes you have to create your own clean barrier. So we do that with newspapers. Sometimes it used to be newspapers. We'd carry newspapers with us because we could use that. So that's the bag. So anyway, so I've done all that in the morning. Now I call my first patient, and my first patient says, well, that time isn't a good time for me because can you come at another time? So now I'm quickly trying to figure out how to rearrange my schedule. And then I get all that done. I've made my lunch because, I've got to eat. So I've made my lunch and my extra water to carry with me. And I've done all of that. And then finally, I'm ready to get into my car and drive to my first patient, and nowadays we use GPS too. So when we're driving around, we plug everything in.
Yeah. And you could use certain apps for scheduling and put all the addresses as needed, or have some sort of automation. All right. So the nurse is packed up and she's got her route plan. She pulls up to the first patient's home. Walk us through what actually happens from the moment she walks in the door.
So the first thing that happens is before she even walks in the door. So she looks at access into the house. So the first thing I do is depends on if it's a home or an apartment, but the first thing I do is I look at access. How easy is it for the patient to get in and out of the house? How many stairs are there? If it's a home, how many stairs are there from the drive? How long is it from the driveway to the front door? Because that's an ambulation issue. How many stairs are there to get to the front door? How steep are they? So now because remember, I'm thinking, I haven't even seen the patient, but I'm already thinking, what's the egress like? What's it like for this patient to try and get out of the house to get to doctor's appointments and that kind of thing? One of the things that I'm expected to do is to do emergency planning with the patient. So fire safety. So if there's an emergency in the home, what are the exits for the patient and family to get out of the home, and how safely could the patient do that?
So when you're walking in, you're already kind of looking at it, kind of sometimes how we go do real estate and look at the foundation and walking around the house.
No, just the entrance. But I'm actually looking at egress and entrance and egress. If I'm in an apartment, how narrow are the stairways? How many stairways are there? How easy? The patient lives on the third floor. Okay, now I'm already thinking this is a sick patient. I'm going to have to talk about how they do emergency egress and how are they going to get to the doctors and what the plan is, right? So I haven't even made it in the front door, and I'm already thinking environmental safety for the patient and egress potential in case of an emergency. Now I knock on the door and I hear a dog barking. Well, I've already told them that they have to have their pets away. And if I've already asked, or they've already been asked, if I didn't do it, somebody did it, scheduling did it, when they verified the address and said, do you have any pets? Well, yes, I do. They need to be secured. And so now if I hear a dog barking, before I even enter the door, I have to say, hi, Mrs. Smith. I can hear your dogs right at the door. Could you please put your dog away? And then I'm ready to come in, because I don't know this dog. I don't know what kind of reaction I'm going to get from the dog. And we have had nurses have dog bites before, been attacked by dogs.
No way.
So we have to be really careful. Cats scratch nurses, right? Pets do things. So we now say you can't have your pet. And what we tell nurses is that you may love pets and say, yes, that's fine.
That's what I was going to ask. What if you're a pet person? Because I've been with people, they're like, oh my God, this is so
cute. We have to say, I'm sorry, but for the nurse's safety, oh, the dog is so sweet. I understand that, but we have to protect the nursing staff.
What if the nurse wants it as well?
We tell them, and that's a really great question. We tell the nurses, you may be a cat person, a dog person, but The next person that follows you may not be.
That's
I'm
a good point.
allergic to cats. I am allergic to cats. So I will go in a patient's home who has a cat. But if there's a thing that says patient has 23 cats, I'm going to have to call up and say, I can't take care of this. I can't go see this patient because of my allergy, right? So we want to protect the nurses as well as protect the patients or the clinicians. It doesn't make any difference. So I knock on the door, no pets, or the pets away, and I walk in. Then I start looking at the environmental aspects of the home. Is it clean? Is there an opening that's easy to get to? Am I dealing with a hoarding situation where the environment is just unsafe from a physical perspective? Where are the trip hazards? So I'm starting to look at that. And if the patient is the one that answers the door, I'm watching the patient walk back to wherever we're going to be to sit and talk. And I'm looking at their gait. Are they safe? What's their gait like? What's their gait like? And are they a safe ambulator? That's the thing. Are they holding on to the walls, which tells me that their ambulation is not stable, that they're not a safe walker? Are they limping? Are they dragging a leg? I mean, I'm watching all those gait things to see.
So you're basically a detective the
Right.
moment you walk in and scanning, the throw rugs and looking at whether there's food in the fridge and medications are
Right.
actually being.
I haven't even gone to that part. I'm just walking in and I've said, hello, I'm your nurse. And they've said, okay, let's go here. And none of that other assessment has happened. So you're right. From the moment you pull up into the driveway, you are a detective. You are really looking at holistically the patient's living situation before you even get into the physical status or the mental, emotional status. Before you've asked those social determinants of health questions you have to ask, you're already starting to make assessments.
And there's a lot of observation, looks
A
like. And I
lot.
don't think people realize how much of home health is just observation. I
You,
mean,
you,
being that detective.
you use all your senses when you're a home health nurse, your smell, your sight, your touch, emotion. I mean, you use all of those senses to get an idea of what's going on. You walk in the house and there's this weird smell in the house and you're thinking, okay, what is that? You're also, and that's even before you've talked to the patient. I mean, you touch the patient. When you're doing wound care, you're smelling the wound, whether you want to or not, right? So, and the smell is telling you things about the wound in addition to what you see. So, and you're touching the skin. So we really do use all of our senses in home health.
Yeah. And there's this thing that's so different, which is so different from a hospital. Like at a hospital, and you mentioned this in our first episode as well. In a hospital, the patient's on your turf.
Right.
Like you said, like you wake them up and you go to them and say, hey, what do you need? And you run the tests on your schedule. But in home health, you're a guest and you're in their living room. It's their dog staring at you. It's their family that might be suspicious of you. Like you have to really almost earn their trust in those first few minutes that a hospital has built over, at times days. And that's completely a different skill that I feel like a home health nurse is so blessed with and is often utilizing when she's going. Like building that trust early on is just so important for them to even take the care and listen to your instructions.
Yes, absolutely. And one of the other reasons you're looking at the home is because I've been in homes where the bugs were so bad that I did not sit down, that I did not put my bag down, that I did the entire assessment standing up while I was taking care of the patient with the bag slung across my shoulder because the environment was not good. And I then had to talk about either having to remove the patient so we could fumigate the house or get social services in. So what are we going to do? Because the house is the patient needs the care. It's not that they don't meet the criteria, but again, it's not a safe place for the patient to be because of the bug situation. And,
Wow.
I'm not going to take those bugs home with me.
Yeah. And bugs is still one thing. At times, people get in certain situations and cycles, like you mentioned earlier, hoarding. And I say this from my personal experience. I had bought this investment property at a foreclosure auction. And then when I went there, and the tenant had been living there for 20 years. And of course, I needed to inspect the property. And I talked to her, and she was an elderly woman. but I saw that, oh my God, even the doors were like blocked because of boxes. The whole section was blocked. That she had lived there for 19 years, and this is back in 2021. So now she's lived there for 24 years. Then, I mean, people can sometimes get in such situations where, either like you said, there are bugs, but then there can be that they're not able to take care of themselves, or they're a hoarder, or they have certain OCD that it just is not a good living situation. And similarly, like animals is another level as well. If you don't mind, tell us some stories that you may have heard that could help other nurses, clinicians who can learn from those experiences.
Before I get started, I just want people to know that this is not the majority of the cases. I mean, these are interesting stories because they're more of, the exception to the rule, but you don't want to think that every time you walk into someone's home, it's going to be this way. I do want to emphasize, though, that this is just like first responders, just like police. You never know what you walk into until you walk into it. Because if the referral's coming from anywhere where the referral's coming through, the patient went to them. And patients do things like put on cleaner clothes and take baths and not talk about their hoarding issues so that they give a good presentation. If they're in the hospital, they're being bathed or taken care of, and they're in hospital gowns, and they're making sure they're clean and doing all that kind of stuff. I'm walking into their home. Sometimes they're dressed like they're having company, which is, great. It's lovely to see the people that, put their makeup on and did all that kind of stuff because I'm coming into their home. So it's almost, and they're like, do you want some tea? I have some cookies. And of course you have to say, thank you so much, but no, thank you, because we're not there for that. And those people, it's lovely to walk in those homes, but then you also walk into homes and, the pajamas are still on, or the underwear is on. I've walked into homes where people have shown up in their underwear, and I have to say, hi, could you go put your clothes on for me, please? And, can I help you put your clothes on so I can watch that you can put your clothes on? And there have been homes that I've been into that the cat wasn't put away and was really friendly. And I had to say, look, I can't have the cat sitting on my lap, the bird can't be flying around the house. I understand you can see the bird has free range, but when I'm here, put the bird away. I've had to do wound care where I said, okay, the dogs and the cat, they can't be on the bed with us. We're doing your wound care. So let me, get them put away. So, it just, that's what happens with pets. And no matter how often you tell them, there are just some people that say, this is my child. And so then you just have to say, well, for this period of time, they're really friendly. And some dogs are, I've been in homes where the dogs just spent the whole time just sitting on my feet. Just, it's like, oh, they really like you. That's great. They really like me, but I need to get up. And then there's other nurses that have situations where the dogs are friendly, but we're taking care of the patients. We're putting the blood pressure cuff on. Could look like we're harming the patient, and the dog is getting upset, right? So, or the cat is getting upset, very territorial. So that's another reason why they have to go away.
That's a good point. I never thought of it that way. Yeah.
Yeah. So we go into the house, and then we start the assessment. We ask the questions that we need to ask. We verify information that we need to double check, make sure their social security number is correct. Some basic stuff that we have to make sure. We do the medication reconciliation on the first visit. Well, actually, we do medication reconciliation every visit, because you don't know we're not seeing them every day. So I'll say, Mrs. Smith, since I was here last time, did the doctor change your medication, give you any new medication? So I'm really doing medication review and reconciliation every visit. First visit takes a long time. There's a lot of questions to ask. We're getting a lot of information that we're using. I think one of the other things that we do is we ask really intrusive questions, but it's important that we do that because people get embarrassed and they may not want to tell you the truth. We have to have the truth so we know what we need to do for you to help you get better. I remember one time I went to a patient's home, and the patient, sometimes people who have had drinking issues their whole life have a certain look, especially when they're 70 and 80. And after a while, you recognize it. You recognize what you think you're seeing, right? You don't want to assume, but you can say, wow, this person looks like they've spent a long time drinking. And I had this one patient, and I asked her the question, do you drink alcohol? And she said, yes. And so I said, how much do you drink? She said, I have a glass of gin and water Is it gin and water? Yeah. Gin and water, a gin and water every night. And I said, okay. And I said, how big is the glass? And she, a tumbler. She told me it was not a tumbler, but like this size of a glass, right?
Okay.
So that size of a glass. And I said, gin and water. Okay. And so then I said, and I wrote it down, one a day. And I wrote that down. And then I said, I need to wash my hands. I'm going to go into your kitchen. I'm going to wash my hands. And that was absolutely fine. She stood there. While I was in the kitchen, I opened the door to the refrigerator. In the refrigerator, there was one of those big gallon jugs of, no, it wasn't gin, it was vodka. Vodka, one of those big gallon jugs of vodka and a lemon. And that was it. That was all that was in her refrigerator.
No way.
That was it. So I washed my hands and I came back and I said, so when you have your vodka and water, how much vodka? And I held up the glass. How much vodka do you put in the glass? Well, this much, right? And it's like she took the water and passed it across the sink. That was it. That's a whole different thinking about this woman's drinking. Because when she said vodka and water, I thought a shot, because that's normally what people do. By opening her refrigerator, which people may have thought was intrusive, I learned several things. I learned, first of all, that her alcohol use was much higher than I thought it originally was, and that she had no food. She had nothing in the refrigerator. And I also looked in her cabinets to see what was going on, and she had no food, which then led me to ask the question about nutrition differently, because I didn't assume that she was eating. I had to carefully ask her the questions about what does she eat, when does she eat, how does she get her food, what's her normal, and then say you do this. Let's go in your kitchen. Well, then as soon as I said, let's go in your kitchen and look, then she said, well, and then she had to be more realistic to me. Those are intrusive things to do. Those are intrusive questions, but we're going to get the answers that are the true answers. Doctors don't necessarily get them. Hospitals certainly aren't going to get them. Clinics aren't going to get them. We're going to get them. So we have to ask those questions, and you have to be willing to get up as a nurse, walk around the house, have the patient walk around the house. We have to answer questions about how well they dress. So we have to see, can they manipulate the buttons on their shirts? Can they tie their shoes? Do they not? What's their fine motor coordination? Because that's what we're really getting at. Can you get yourself dress tested? There's a whole lot that goes into it, including fine motor coordination. Many old people ditch the buttons after a certain age because they just can't manipulate them, right? So they go to slip on shoes and slip on pants and, that kind of. So the answer is yes, they can. But then you're finding out that their fine motor coordination isn't good. So maybe they can't pick up the pills and so now they have medication administration issues. Do you want another story or no? I can tell you.
Yeah, of course. Keep them coming. But I'm just trying to place myself. So the nurse woke up, did all of the things that she had to, living her life, and then important things to check the schedule, match the schedule. If it's an older EMR or still some syncing, then you need to download or somehow whatever that needs to happen. And then once you've got your schedules, then you know that, okay, these are the different patients that you must go to. And then you decide based on your location, put it into your map, and then you show up there, you're being a detective. And then you mentioned that all these things that you must do when you're at the home, including being a detective and observing all the things and doing a complete holistic assessment, doing the medication. And then what happens next? So you finish your assessment, I guess.
So you're documenting the whole time. So while you're there, your laptop is open. You need to document in the home as much as you possibly can. I think one of the biggest challenge home health nurses have and have had forever is the feeling that they have so much to do, they don't have time to get it all on paper. They'll get the vital signs down. Those are numbers. They know they're not going to necessarily remember the numbers. So they'll get the numbers down that they have to get down. But everything else, they may think, okay, I'll remember this. But we know from studies that people, by what you do at 8 o'clock, by the time 5 o'clock, 6 o'clock comes, people on average remember about 20% accurately. They may think they are remembering, but they don't remember. And when I'm talking to new nurses about becoming a home health nurse, I will tell them you're going to see anywhere from 4 to 7 patients probably in the day. And these patients are completely different. You're not going to see 4 heart failure patients or 7 heart failure patients. You're going to see people with orthopedic diagnoses and cancer and diabetes and heart failure and new knees and dementia. You're going to see all these people with all these diagnoses, and trying to keep them all straight without documenting as much as you can at the time that it's happening is a disservice for you and a disservice for the patient. The challenge with the initial assessment is that it's so long and there's so much to document. You're not going to get it all done in the home the way we do it nowadays. And you never could. When I was doing field nursing, though, I would get all of my documentation done by the end of the day, except my starts of care, because there's so much to do, right? And then nurses will say, well, I feel like it's a barrier. And what I will tell them is that I have never, when I have asked a patient, is it all right if I write this stuff down now, that I take these notes now? I don't want to forget what you've had to say. So I want to make sure I get it on paper. Is that okay if I write it down? Not one person has said, no, don't write it down. It's okay if you forget. No one says that. Everyone says, oh, yes, please. Mary, the other nurse, she never writes down anything. It's so great to see you write stuff down. People are fine with it. They're fine if it's pencil and paper. They're fine if it's the laptop, as long as you make eye contact. If the whole time you're talking to me, Arvind, if I'm like this the whole time, then I'm not connecting with you. And True. That is bad. And we have to make sure we connect. But if I connect with you while you're talking, and I say, okay, just a minute, let me make sure I get this down. Majority of people will sit patiently while I type. And then I come back up and go, great, I got it all down. Now let's talk about documenting during the visit is an essential part of the visit, a thing that a lot of the nurses struggle with the most.
And that's why, are solving this problem here with Copper AI of really understanding what goes into the documentation and how can this be made easier. And the important thing here is to not think that a home health environment is going to be a similar environment like a hospital or a clinic, and then the traditional scribe is going to work, because Of course, a lot of the people look at the scribe has been around for a very long time. Ambient scribe's been around for like decades now. I know that there are a lot of jobs offshore as well, where the job of the transcriptionist was, or maybe still is, to just review those audio notes from the doctor and transcribe those. So I know that that's traditionally how it works. So it's logical that a lot of people think, oh, do the same thing for home health nurse. No, but as we just established, it is a lot of that detective job, and it's a lot of observation. And when you're going out there, you're not gonna like verbally say everything in front of the patient. Like in our discussions, when we're innovating on the product and coming up with, the empathy maps and the journeys, we're like, there are certain questions that the clinician cannot answer, because even if it's not a scribe, if it's a two-way agent, or if it's just a tap, whatever that input mode might be, you might be just taking a picture of the notes and then from that converting it to a starter care. But then again, it is just very, very difficult to compare that with exact same that happens at a hospital or a clinic.
Correct. You have to recognize that when you're in a home environment, you're in an uncontrolled environment, and the equipment that you use has got to make it easier for you to do your job. When we first started with EMRs years ago, people would say, oh, it'll make your life so much easier. Well, it didn't. I mean, it made it easier for the agency with the transcribing, and it made it easier for data collection. Absolutely. But it did not necessarily make it easier for the clinician to get all the information. And a lot of it is because when they're creating the EMR, the data input follows logic, but when you're in a patient's home, you're seeing things all the time. The advantage to doing it on paper is that I could flip to the page that I needed to flip to, right? But in EMRs, you can't. You have to go in the order that the EMR tells you that you have to go in. When we had to start doing Oasis, the EMR, the start of care document got so huge that it became unwieldy to do that non-electronically. It's now 23, 25 pages. Well, there's no way, that you're going to be able to do that. So it's actually easier to do it using a computer, but now you have been stuck doing it the way it's set up and you can't flip over and say, you don't have a menu that says, no, I'm going to talk about this now. And then I'm going to go back to this and stuff. Some are getting there to do that, to make it easier to go back and forth, but it's still definitely a challenge. So now I'm in the patient's home. I've done the assessment. I've got a clear idea. I've talked to the patient. I've reviewed the documentation before I left the home. So I reviewed everything I could before I left the home, either the last visit note or the referral information. So I had an idea. Now I probably have also, just before I walked in the patient's home, pulled it up again so I could remind myself again. Because remember, if I looked at it at 7 o'clock in the morning and you're my 4 o'clock patient, I'm not going to remember what I did. What happened to you? And so I'm going to come back just before I walk in the house. I'm going to look at it again. And I forgot to say that, but I am going to quickly do that. So now I'm at the point where I have a pretty clear idea. It may not be on paper. It won't be on paper yet, but I have a pretty clear idea of what your plan of care is going to look like, what your care plan is going to look like. So that, because your care plan are the goals and interventions that you and I are working on together so that we can meet your goals. I've asked you what your goal is. So I've asked you, what do you want to accomplish from these nursing visits? What's your goal? I often tell people that it's important to ask patients what their goals are. My goal for a patient with diabetes may be to get your A1C to 5.8. That's my goal for you. Patients have never said to me, oh, my goal is to get to an A1C of 5.8, right? They say, I don't want to lose my eyesight. If I had diabetes, my eyes are not doing better. I don't want to lose my eyesight. I hear people with diabetes lose their feet. I don't want to lose my toes or my feet. I want to be well enough to attend my granddaughter's wedding. One of those are the goals. So then I know what your goal is. And if it's realistic, that's great. If it's not realistic, that triggers me that I need to have a conversation with you. Because if I know that you are at the terminal stage of your terminal illness and you're saying, I want to get well enough so 2 years from now I can, go to Paris, and clearly you're in the terminal part of your stage. I know that you're not where you need to be. And that's a whole different conversation that we need to have with you, with your family, with your doctor, with everybody, right? So I've learned more information about you.
Some of this we talked about in our second session as well. So for the
Right.
audience, whoever's interested, there's the documentation beast, all about Oasis and
Right.
what goes in it. So after the first visit, the nurse gets back in the car and does it again. How many patients does a typical home health nurse see in a day, and what happens between visits? Is she like just driving or waiting at a parking lot or going to the home office, or is that in between is when the work is happening for the documentation?
So, all of the above. So she or he are leaving. So now I've done the patient's visit. I've done the intervention, all that stuff. So now I'm back in my car. Now, if I've been able, depending on what happened with that visit, the other thing I'm doing in the patient's home is I am calling the doctor if I need to call the doctor, right? So I'm trying to call the doctor in the home if I need to do that. Now I'm getting back in my car. I could be calling I could be checking in the office about stuff going on. I could have gotten called by the office while I was in the patient's home. So I'm calling the office back and saying, hey, I just got out of Mrs. Smith's house. What do you need? And then they're telling me that my schedule's changed yet again, or anything. They're telling me whatever they tell me. It can be, some of it could be that my schedule's changed again. And now I'm either sitting in the patient's driveway, but chances are not, because they're wondering why I'm still sitting there. But I'm going to a safe place, because a safe place to park your car is really important. So I'm going to a safe place to park my car to then talk with the agency and say, okay, who am I going to see him? How am I going to rearrange it? Okay, would you call this patient? Would you call that patient? I'll call this patient. And so I'm rearranging my day. They could have called and said, doctor so-and-so called back and changed the orders. And so I'm going to be doing that. I could be on the phone with another doctor. I could be calling the PT and leaving a message saying, hey, I just stopped with Mrs. Smith and I'm giving a report now on what happened with her because I see that you're going to see her tomorrow. So there's a lot of things. I could be eating my lunch. I could be trying to find a place to go to the bathroom. I could be doing a lot of things. Some nurses find safe places to park their car and sit in their car and finish their typing and finish their note in the car. And we work all over the country. So I'm not doing that in the Northeast. I'm not sitting in my car in the Northeast when it's 14 degrees out any longer than I absolutely have to. So I may be going to some place where I can tuck myself in a back corner where no one can look at my laptop because of HIPAA and get a cup of coffee and do something there. I'm definitely driving to my next patient. How many patients am I seeing? It depends on what my schedule is. If I have just starts of care, then I'm only doing probably 3 because it's an 8-hour day and each is going to take 2 to 3 hours. And that doesn't include travel time. So, because don't forget, I have to include travel time.
That sounds more manageable because I've also heard when I was at the National Alliance of the Care at Home, like nurses are expected to do 5 to 7 visits.
Yeah, but that's not what I'm talking about. I'm talking about a start of care, right?
Okay.
So if you think a start of care is like 2 visits, right? Or 2.5 visits, then what you're really talking, if I just have return visits, no new starts of care, then I'm going to be doing on average 6 visits a day. That's the expectation. And a visit is 1 point. So it's a point value. So if a visit is 1 point and you have to do an average of 6 points, that means some days I'm going to do 5 points. Some days I'm going to do 7 points. And if I have a discharge, then some agencies give you more points for that. If I have a resumption of care, it's going to take longer. So I'm going to get more points of that. So the number of patients you have greatly depends on what you're doing for that patient.
So let me do the math then.
Right. So it's all math.
Got it. So each visit, though, you meant like a regular visit, still 45 minutes to an hour, right?
Right. Plus, 30 to 40. Yeah. 30 to 45 minutes. If it's an hour, it's beginning to get into that longer stage, but yeah.
Got it.
But don't forget, you also have travel time. So if I have a wide geographic area and it's 45 minutes between patients, I'm going to do less patients.
Even if it's 20 to 30 minutes, I mean, between each patient, plus the documentation at each stop, right? Like whether it's in the home or as soon as you get back to the car, because there may be certain things that you don't want to put in your scribe or answer questions for your voice agent. I mean, that's when you add it all up with 5 to 7 visits, that's a 10 to 12 hour day before you even get home. And then you still have to do charting. Then when does this person eat? When does she see her own family? I mean, this is not looking good.
So this is what happens. Most nurses will, not most nurses. If you're a nurse with small children, the advantage of home care is the time flexibility on one end. So if I need to pick up my kids, I can build that into my day, right? Generally speaking, not always, but generally speaking, I can build my visit day. So I'm getting a lot of my visits done. So if I have 5 patients and you figure every patient is about an hour and 15 minutes with driving or an hour with driving, right? So now you're into 5, maybe 6.5 hours out of an 8-hour day. The advantage to home care is that I can go home, I can take care of my family, but then I'm back doing my work at 9:00 at night. The challenge is that by 9:00 I'm tired and I should be able to get it all done before the end of the day. Now, those people that are getting done in that 5.5 or 6 hours, they're not doing any documentation. They're not taking that extra time to document their visits. They're not doing that. If your day has completely fallen apart, though, you could say, I have a hard stop at 4:30, 5 o'clock. I have to be done by then. And then you're still sitting up at night doing your documentation. And if you're new, you're not as fast with your documentation as if you have been doing this for 100 years. So you just learn how to do it efficiently and effectively and quickly. But also remember, your documentation is not just your visit. It's your care coordination notes. It's your doctor's phone calls. It's the meetings that you've had that you have to have on top of it. It's the fact that you're going to be doing those 6 patients and you're going to be doing a team meting in the same day. So now you have.
I'm guessing it never goes according to the plan. Like patient number 3 has a fall, or patient number 4's family, is in crisis and needs 30 extra minutes, or someone's not at home and you show up even though they confirmed yesterday. Is there such a thing as a normal day in this?
I think that's I would say for most home health nurses, what you described is a normal day, right? So it's like saying to an ER nurse, is there a such thing as a normal day? And she'll say within the parameters of the ER, yeah, but nobody died today. So that was good. But I think so with home health, I think the key is that you have to be really flexible, and that there are things that there are things within our parameters that are normal that you can just say, okay, the patient fell. I know what to do. I can deal with that. When it becomes really not normal are when those things happen that they're just really outside of complete parameters. The street has been flooded for, 7 blocks, and now you can't get to the patient. We had the snow apocalypse. So we knew the snow was coming, right? So we triaged all the patients and said, no, these patients have to be seen. But now you're trying to get to that patient and there's no way to get to that patient. Or you've gotten to that patient and you can't get into the driveway because nobody's plowed. Or the driveway is okay, but there's no way to get in. Many nurses in the Northeast carry shovels with them just so they can shovel in if they need to. They carry kitty litter so that if their car is stuck, they can get themselves, those are not typical days.
What strikes me in a hospital, if something goes wrong, you yell down the hall, there's a team. In home health, you're alone. So you
That's
walk
right.
into a situation and you're the only clinician there. And that takes a very caring and a kind person. And I don't think we appreciate that enough. And I think that's what a real home health nurse does.
And really people who think outside the box. I have had clinicians come up with the most ingenious ways to get things done in the home. They'll say the patient doesn't have money for this. We rigged up this walker kind of, and I'm like, wow, how inventive. Our good home health nurses are really out of the box thinkers. They really think on their feet. They're very empathetic, but they also really recognize that a typical home health day is not typical.
Yeah.
You get what you get and you roll with it and you figure out how to make it work. They also have really good instincts. So if you're in a situation that isn't going right, they know they know when to go, nope, not walking in that house. They know when to say, you know what, I need to get in my car and then call the agency. Because I think that, yes, you're absolutely right. Home care staff are alone, but they're never really alone. The agency is just a phone call away or just a beeper away. Many home health agencies are doing emergency response for their clinicians. And it's one of those things where you pray to God you never need to use it. But if you need to use it, it's there for the clinician for peace of mind. So they become very aware of situational awareness. I mean, as a home health nurse, I was a home health nurse in Detroit, and then I was a home health nurse in Los Angeles. So you get really aware of your surroundings. And then what happens is then you become always aware of so I'd be on dates and I'd be aware of my surroundings. So that sense of that sense that you have of being aware of everything, I think is something that home health nurses bring to the table that you don't have to do when you're in a hospital and you're in a relatively safe environment.
Yeah. You got to have your instincts spot on and,
Mm-hmm.
third eye.
Mm-hmm. Yeah.
Okay.
So when you're done, you've done your day and now you're home, right?
Last patient seen, nurse gets in the car, heads home, but the day isn't over. And that's where I wanted to understand the documentation and how long does it take? And I guess also what's that emotional toll at that time?
I think the challenge is that you want to it depends on what you've done with your day. If you've done what I've tried to teach you to do, which is to do your follow-up notes in the patient's home, it's really less of a burden. I've had 1 or 2 nurses that they would end their day in the office every day because they said, when I go home, I'm mom or I'm dad. I don't have time to do all this stuff. And I'm not staying up till 11 o'clock to get it done. So they would come in and they would do all of their phone calls, all of their notes. They would plan how they would get their start of care done. And then they'd walk out at 5 o'clock and they'd go home and they were done. That is the exception to the rule. Most everybody else loves the idea that you can be home by 3 o'clock in the afternoon. You can be home by 4 o'clock in the afternoon. Then take several hours to do what you need to do. But then it's 9 o'clock at night and you're tired and you still got all this documentation to do. And that emotionally is a challenge. Sometimes you have to remind them that they didn't put in 8 hours. It's like they did a split shift, right? And that may be logical, that it's true. You worked from 8 to 3. So you'd have another hour and a half of work to do. You got it to do. If you do it and we don't care if you do it at 9 o'clock at night or 10 o'clock at night, it gets done as long as it gets done. As opposed to the hospital where you couldn't say, look, I'm leaving at 2 today. I'll finish my documentation on this patient about 9 o'clock tonight. The hospital would say, I'll sit there, right? Are you kidding me? You're going to sit there and do that.
So see, that's still one thing about like
but I was going to say, but it's still hard. It's still emotionally draining to think, oh my God, I got to get back and do the work. Now I'm tired. And so now I don't remember as much as I did before. Now I feel like I am never away from this job. And I think that's the downside of the fact that documentation can become onerous. And as I said, Oasis is the biggest issue because it's doing the assessment, writing the care plan, doing the clinical visit note. All that stuff has to get done. It's not just the visit. It's all the other stuff that goes along with it. Making sure that you've completed all the documentation correctly. All that, it's a lot. It takes a lot of work.
Absolutely. And so what you're describing is, so the one issue is like when to do the documentation. You want to squeeze it in between the visits, or when you're ending the day at the office, then you just are like, okay, let me just get it done because then I want to be completely done for the day. But often, you may be in that phase of your life where you're like, hey, let me take more visits. If you're getting paid per visit, then you're like, let me maximize that and get home at 6:30 and then quickly do dinner and then put kids to bed and be back and doing the documentation. So I guess it's one thing like when the documentation is done, but what I want to understand also is how long does it actually take to do the documentation? Because whether you do it earlier or you do it at 9 o'clock, there's still, I've heard, like a lot of time that goes into it. And that time, like I've seen the data and, it says 40% of the shift goes on documentation, like 40%. That means you're working like, 12-hour shifts, almost 5 hours of paperwork. I mean, that's really crazy.
Again, I think it depends on what you're doing. A visit note, it's such a challenge because if you're a newer nurse, the challenge is, well, being a newer nurse and the EMR, sometimes they make it easier, sometimes they don't. The challenge that people have that I talk about and teach about is learning how to document smart. So you can do a thorough explanation of a patient and use less words, but that's a skill that you have to learn how to do. And there's a real disconnect between the way you chart in the hospital and the way you're expected to chart in home care. So if you've come from the hospital with tap, 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 4 words, you're done, right? And now you're into the home where I'm expecting a clinical note with complete sentences and words that are spelled correctly and a clear understanding of what you instructed, what the patient's response was and what your plan for the next visit is and what your assessment is, that becomes more complicated to do.
In medical terms too.
In medical terms, yeah. And I think that becomes more of a challenge for clinicians to do. Again, you're always going to have that 10%, 15% that just fantastic. They do a fantastic job. They're very clear on it. But the vast majority of people need a couple things. They need a clear understanding of what they need to document, how they need to document, and then they need the time to learn how to do the documentation. So if someone says to me, I'm spending most of my time doing the documentation, then I'm going to want to sit down and talk to them about what are they doing and how are they doing it and some shortcuts that they can get to. It's still a lot though. And when you talk, because of what the kind of documentation it is, when you think about, again, the documentation that happens in a clinic, the documentation that a nurse does in a hospital versus the documentation that is done in home care, it's completely different. And you can't come easily from the one into the other. Now, I would assume it's easier to go from home care into the hospital because you're going from lots of words to tap, 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 tap. So I think that makes a difference. And again, when we go back to the start of care, the resumption of care, the discharge summary, or the discharge Oasis, all those Oasis time points, there is a lot of documentation. There's a lot of documentation just to answer the Oasis and answer the assessment. And then there becomes the documentation for the interventions. And again, I think part of the other thing is if you're doing the clinical note doesn't necessarily, once you get good at it, shouldn't take you a long time. But now you got to update the care plan. So now I'm going into the care plan document, getting out of the note, going into the care plan document, and now I'm updating the care plan and saying I've met the goals or didn't meet the goals or whatever I did. Now I've also called the doctor. So now I'm documenting that visit. I'm documenting that I'm calling the doctor And then after that, I have to write the doctor's order. Because remember, in home care, doctors don't write the orders in home care. They give them to us verbally. We write the doctor's order. So now I've got and if he's changed anything, I'm going back in and I'm updating the care plan, or I'm going back in and I'm updating the medication record. So when we think about documentation in home care, we have to recognize it's not just the visit note. It's all these other pieces that have to. If I've talked with the PT and we've had a case communication, I have to document that case communication.
Right. So there's not just Oasis, but the clinical note, the verbal orders, and then the care plan, updating the care plan, updating the medication, keeping any notes of care coordination. Because if you don't have any of those, then you could get audited and get some sort of repercussions because of that.
Right, and because we have to prove that we have care coordination on patients that have multiple disciplines in.
Absolutely. And it's not just time. It's what that time costs you as a person. Like, you're sitting at a kitchen table at 9 p.m. documenting a visit that you made at 10 a.m. Your kids are in the other room. Your dinner's cold. And you're trying to remember the exact details of a wound you assessed 11 hours ago. I mean, that's not a documentation problem. That's a quality of life problem. And it's why nurses leave.
Yes, that's definitely one of the reasons why nurses leave, is because because of the time that's involved in it. The other challenge, I think, is when I get new nurses in, they think it's going to be easy. They think, oh my God, it was so hard in the hospital. It was so much work. I worked and regardless of what unit they were in, it was really, really hard. I'm going to go to home care because it'll be so much easier. All you do is you see 4 or 5 patients, you sit around, you have tea, you chat for a little bit, you have a good time, right? Play with your dogs. And I really do think that they really do not understand what is involved. And so they are really ill prepared for the experience. And that's why a lot of agencies have started doing ride-alongs. Because it's like, here, let's show you what you're getting into, right? So you can be clear on that. The other thing that happens is that I don't think a lot of agencies consistently do a really good job with orientation and with education. I think we can do a much better job with preparing our clinicians for what it means to do all of the things that I just talked about today. And I think if we don't prepare them well, then they get overwhelmed. You know, we talk about it takes 6 months to learn a new EMR. Well, it takes 6 months to a year to learn how to do home care. And unless you had home care as part of your educational experience and universities don't consistently teach home care anymore like they used to. If you're going to a 2-year program, you're probably not getting home care. You're getting community care, which is clinic nursing. So they come to home care with no background. So they didn't get it in school, and there's nothing that has prepared them from what the work they were doing for what it means to move in. So think it's going to take 6 months to a year to really have a home care nurse who feels like they know what they're doing. I used to tell people when you did this manually, if you don't balance your checkbook, you're probably not going to make it in home care, because you have to be organized. You have to be personally organized, because think about all the stuff you had to do before you even got your day started, right? If you forgot to check your supplies and you walk to that patient's home, now you can't do the care you need to do because you didn't check your supplies and make sure the supplies were there. When you called the patient, you didn't ask if the supplies were there. Now you're not doing the wound care. You're not following doctor's orders. So now what are you going to do? Now you either have to figure out how to get to the agency. You have to figure out how to get to the agency and get back because you have to do the wound care per doctor's orders, right? So you have to be organized. If you are organized, you will get through your day. If you're not organized, then you're going to have more challenges with your day. Writing the notes, as you said, is part of it, but you have to pull it all together in your head before you even get to the point where you're writing the notes. Absolutely. You have to do your notes in the home. As much as you can do in the home, you have to do in the home. And the nurses that succeed are the nurses that do it well. The nurses that get frustrated are the nurses that are at 9 o'clock at night, 10 o'clock at night, and they're still doing it. And they're feeling like they're never leaving it. So from an individual clinician, that's one thing. An agency that doesn't support the clinician, that is constantly changing their schedule, that is trying to throw too many patients on them at once. All those agency dynamics also contribute to people leaving nursing. home care
Totally.
nursing.
Well, absolutely. I think here's what connects everything we've talked about in this series. I mean, the documentation burden leads to burnout. We know that. And that burnout leads to turnover. The turnover leads to staffing shortages. Staffing shortages lead to rejected referrals, and the rejected referrals lead to patients not getting care. It's a chain, and the documentation is the first link. Wow. I mean, Kathy, last question, and this one's personal. If you could tell a brand new nurse who's about to start in home health one thing that nobody told you in school, what would that be?
I would probably tell them that home health nursing is to me the best nursing. The things that I used to get in trouble for doing in the hospital, holding the patient's hand, listening to them talk, really teaching them about their disease process, sitting on their bed, are the things that I'm supposed to be doing in home care. So, and the things you really got into nursing for. I mean, if you really got into nursing because you wanted that fast pace of ER, then home care is not for you. Home care is slow cooking. So if you think of being a chef, again, that analogy, home care is really slow cooking. The stuff goes in the pot and it takes a while to cook. But that's the exciting part. Knowing that I made the difference. When I was in the hospital, I was the blonde nurse that worked days, right? But in home care, I'm Kathy. And that connection that you can make with patients is just unique. I get to spend 30 to 45 minutes with a patient. Nowhere else do you get to spend that amount of time making those connections, helping people become the best part of what they want to be, helping them get their lives if they want to, helping them meet their goals. I think that it's a unique and wonderful aspect of nursing, but it's a calling. It's just like every other part of nursing. It's a specialty. It's a specialty like OR nursing is a specialty and ICU nursing is a specialty. Home health is a specialty. And if you love it, you'll love it. And if you don't, the good news is you can try it and decide it's not for you. But I would tell new nurses, that's what I would tell new nurses. And don't expect to be great overnight, that it's going to take a while. You're going to be a novice nurse for a while. And you may have been an expert nurse when you were in the hospital, but now you're changing to a different profession, a different specialty. So you're going to need to walk through that novice role again at that specialty, but keep with it and you will succeed. It will get better.
I love that. And I think that's the message for everyone listening. Whether you're an investor looking at this space, or a tech founder trying to build for it, or an agency owner who is trying to keep your nurses, you have to understand that these clinicians go through every single day so much. And you have to understand what they go through, because if you don't, the day that they have experienced every single day, if you don't know what that is, then you can't fix the system. Well, thank you very much, Kathy. This was just such an important session, such a critical session for everyone who's watching. I'm looking forward to having more discussions like this with you. So see you in the next time.